talking about things, we want your feedback so that we make sure we cover what's important for you in learning more about these measures. Okay, next slide. I thought it might be helpful just to define some terminology as a framing for this, because we use these words a lot, and just to make sure everybody's thinking about them the same way. So when we talk about assessment, we're talking about the ways that we systematically and in an organized way gather information about the child or the parent or the family who's the target of our assessment. And although we do most of our assessment early on in a case, we're always learning about our children and our families. So our assessment gets modified as we're working with a family. I think Cynthia will add to that as she presents her case. So assessment is how we systematically gather information. When we talk about clinical formulation, we're talking about how you will integrate your assessment findings with your own theoretical understanding, your knowledge of child development, and what you come to learn about the contextual variables impacting on a child or family in order to understand the symptoms that a child presents, in order to best understand the child's symptoms. So it's kind of like your own internal logic model, how you use all of this information and piece it together to develop a formulation that will help guide your work. When we talk about evaluation, we usually mean using all of this assessment information in order to make an informed judgment about a particular question, either a diagnosis or an intervention approach. Sometimes we use assessment and evaluation to think about a school placement or another question that's being asked. So evaluation is the use of assessment to answer a particular question. And a diagnosis is the identification and classification of a specific disorder or more than one disorder. So those are the ways we'll be using these terms today. Next slide. Okay, so why assess? Well, hopefully and always to do something that benefits the child and family, but in more detail to describe and understand behavior, to identify strengths and weaknesses, a child's, a parent's, a family's strengths and weaknesses. Very apropos to this particular conversation, we assess to compare an individual's performance or standard, compared to other children the same age or other parents. So it is to compare an individual's performance, to inform a diagnosis sometimes, to plan interventions, and as I said before, sometimes to recommend an educational placement or other appropriate services. Okay. So to really have a complete assessment, there are often many different components that contribute. We like during an evaluation or an assessment to gather information from multiple different sources or types of information. So including and often starting with one or more clinical interviews with the child's primary caregiver so that we can get both a thorough psychosocial assessment of the family's current context and also very specifically the child's developmental history. Sometimes our clinical interviews also include talking with other collaterals who are important in the life of a child, including their teacher or childcare provider, sometimes depending on the issues, the pediatrician. So an assessment often includes or incorporates information from more than one informant about the child. And then in addition to these clinical interviews, we like to have direct observations of the child as part of an assessment, sometimes if we can in different situations or with different caregivers. And then lastly, although not necessarily in that order, the use and administration of standardized measures. So assessment should be multimodal and have many components to it. Next, Nicole. Thank you. And just to review some guidelines for assessment, if there has been a previous evaluation, perhaps an evaluation from early intervention or some other source, we certainly want to review that. when we start talking to a parent about their chief concern, we want to have a really good understanding and flesh that out as best as we can. So for example, using a common example, if a parent is there because of a child's behavior, of course, we want to know specifically what are the behaviors of concern and when do they occur and in what settings, and do they occur in multiple settings and with multiple caregivers, or are they specific to one place that the child functions in? What happens before or after? So in other words, to flesh out as much detail as you can about the parent's chief complaint. Of course, we want to be very familiar with the family's culture. That's a really important part of understanding a family's presentation. And although the measures that we're going to talk about and other measures are often construed to avoid or eliminate any items that might be culturally biased, and most have been standardized on a diverse population, they're still standardized in the United States and may not reflect the experiences, outlooks, or child rearing practices of other cultures. So results of measures always have to be understood in the context of what you are duty bound to learn about a family's culture and beliefs, especially when they're different from the kind of mainstream culture. Also, inquiring and learning about a family's culture is a really important way to join therapeutically with the family. Okay, and then lastly, we also want to be very familiar with other contextual issues impacting on the child, including, and DC 0 to 5 guides us in this way, understanding as much as we can about the child's health and development, understanding what particular psychosocial stressors are impacting on the child and family, certainly understanding any exposure to traumatic experiences on the part of the child or caregiving adults. And we want to know as much as we can about the child's relational history and the relational context in which the child is growing. Well, thank you. So the rationale for using assessment tools at the beginning of work with families. It ensures, first of all, that important areas of inquiry are conducted so that assessment is comprehensive. And I'll say, you know, I've kind of learned this. I remember one example. You may think that you learn about a family and people's behavior and emotional status through talking with them, and often we do. But I remember an interview I did with a grandmother who really presented so warmly and was such a good informant, and it was quite personable and animated in her interview with me. And I remember that interview because when I looked at her measures after she left, she had scored extremely high on the PHQ-9. She really had symptoms very high for the possibility of depression, and that just didn't jive with how she presented. So I just want to underscore that sometimes we really do need measures to uncover things that are not so obvious in our clinical interviews. It also wards against clinician blind spots or resistance or discomfort. You know, we'll get to the ACE as an example of that at the toward the end of this discussion. Sometimes we are reluctant or uncomfortable asking certain things. So using measures helps us make sure that we don't have blind spots or resistance to checking into certain kinds of information. Again, we mentioned this before, it compares an individual's performance or characteristics against a normative status. And we've said most of these other things. We identify strengths and weaknesses and we plan interventions. But I'll also say that using assessment measures can also be a way to contract with clients about the work to be done to establish a therapeutic alliance as you review measures with parents and check in to see if your scoring and interpretation matches what the parent is feeling and thinking. It is a way to establish some treatment alliance around what you're going to be working on. Okay, next slide. And then assessments for follow-up with families. Of course, in the course of treatment and at discharge, we're often repeating some of these measures, and that's done to check in on treatment progress. Hopefully, we'll see some symptom improvement when we repeat measures. and also for program evaluation. Kristen is on with us this morning, and she asked us to just remind everyone that the mental health treatment data that you all submit is used as part of the program evaluation of the ECTC and the Early Childhood Mental Health Network. So one of the uses of follow-up assessments is to assist with program evaluation. It helps, I think, Kristen, you're mostly looking at the DECA and the PSI for repeat measures to see how the program is impacting families in those ways. And the data is used by the department to help understand who we are all serving in this network and how and what the impact is of the treatment that's being provided. So the follow-up assessments are used to check in on symptom improvement and progress in the therapeutic work and also for program evaluation. Thank you. Next one. Okay, so just some things to consider as we're talking about assessment. It's probably helpful and important to inform parents early on as you meet them that an important part of evaluating their child and developing a treatment plan is the use of standardized measures. We can tell them upfront that some of these measures will be used only at the beginning of the work and some will be repeated at different times during the work. And I'm sure you don't need a script for this, but just to help out a little bit, we can say something like the purpose of these measures is to supplement the information provided in our discussions and to make sure that the assessment is comprehensive and takes into account everything that may be contributing to the child's presenting problems or to the stresses impacting on the family. You can say something like, I will explain each one to you as we go through them and I will share the results with you. And I'll be happy to answer any questions you may have about these as we complete them or at any other time. And then again, the parent can complete the measures independently or the clinician can help the parent complete the measures. And I know we have sometimes have to rely on interpreters, which is sometimes necessary, but I'll just say that if and when you do use interpreters, as I'm sure you all know, they have to be really quite well trained to make sure that they're doing this the way that we need them to do it. Okay, next slide. Okay, I'm going to stop before I go on to see if anyone has any questions about these introductory comments. Okay, no questions in the chat, Nicole? Okay, so we're going to keep. Okay, good. Yeah, I'm just going to keep checking in because I don't want to miss anyone's question. So these are the assessment tools that are used in the network. The child assessment relies pretty much on the DECA. I know that there are 3 versions of the DECA. I'm going to focus today on the DECA-C because I believe that's probably the most commonly used one. The PSI short form, the Parenting Stress Index short form, is used as a parent-child relational assessment. I know that that one has gone optional, but we'll talk about that because I think some of you are still using it, and it's an important one. And then there's a set of screenings, including mostly parent screenings, the PHQ-9, the GAD-7, and the ACE questionnaire. And I'll talk a little bit more about the difference between screening and assessment measures. Okay, so we're going to start by talking about the DECA. So I'm just going to get my DECA. Okay. So the DECA-C is a standardized norm reference behavior rating scale for children 2 to 5 years of age. It is the primary tool in our set of measures for assessing children's emotional and behavioral problems. A real strength of the DECA-C and a difference from other behavior problem checklists or assessments is that the DECA also assesses children's strengths and protective factors. And that's a really important and good way to join with parents by thinking about, what the child's strengths are. The DECA can be completed by a parent or a teacher. It's the same form for each. It results in an individual child profile. And important to say that for the families that come to your clinic, it will probably feel like the most face valid of all of the instruments. In other words, it's the closest match to what the parent expects to be asked when they bring a child to your clinic. Okay, next slide. Okay, so the uses of the DECA-C within the ECTCs, we develop a profile of the child's strengths and needs in the social emotional domain for use in treatment planning. We can compare, if it's of interest, the child's behavior across both home and school settings. And again, we use it to measure intervention progress and outcomes. Next slide. Here's the structure of the DECA. There are two main subscales. There's the protective factor subscale and the behavioral concern subscale. Each one of those results in a total score. Okay, I'll go over the individual subscales on the next slide. So the protective factor scales include three different sets of behaviors. The first is initiative. Initiative speaks to a child who can use their own inner resources to get their needs met in a socially acceptable way. The concept is similar to autonomy and self-efficacy. Children who receive high scores on initiative are usually independent and active learners who will start or organize activities with other children. They tend to be children who are good problem solvers and enjoy challenges. Self-control is pretty self-explanatory. These are children who can handle a range of feelings and express them in a socially appropriate way. They're able to handle frustration and anger without acting out. These children tend to be cooperative, respectful of others, usually share well, often able to self-soothe. Attachment speaks to the nature and quality of children's relationships with other children and with other adults. And children with high scores in attachment usually seek out adults and other children, are usually effective in gaining positive attention from others. So we get individual scores on each of these and then a protective factor score. Okay, the behavioral concern scale includes 4 different subscales. Attention problems, again, these are pretty self-explanatory. Children who have difficulties focusing on a task or ignoring competing stimuli. Aggression, these children usually with high scores on this scale may, take things from others, may even hurt other children, may get into fights or show verbal aggression. Okay, withdrawal and depression speaks to children who are show either social or emotional withdrawal. The child is a little bit more inner focused rather than engaging in social interaction. They may have flat affect or show little emotional reactivity. They also may seem sad. Okay, so that's a dimension that I think is familiar. And then emotional control problems, child who has difficulty modifying the overt expression of negative emotions and usually acts them out. Those are pretty common concerns for young children who present to clinics. And then we get a total behavior concern scale score. Okay, raters for the DECA can be, as we said before, a parent or other caregiving family member. It could be a teacher or other early care and education professional. The guidance is that they need to know the child for at least 4 weeks. We encourage them to respond based on behaviors they've actually seen. The reading level of the DECA is said to be 6th grade, and it is available in English and Spanish. Okay. Okay, explaining the DECA to parents is usually pretty easy because it's self-explanatory and it matches what parents expect when they come to your clinics. Can say something like, the questions on this form describe different kinds of behaviors that are shown by young children. Your answers will help me learn more about your child and the concerns and behaviors you're seeking help for. They will also help me know more about your child's strengths and the behaviors and skills that are well developed for his or her age. Again, I'm sure that this is not a challenge for most of you, but we can always check in with parents and ask them to please let you know if there's anything they don't understand or need help with in order to complete. And again, I'm going into a lot of basic details, and we can go quickly through these. Parents or teachers are asked to check a box that best describes the occurrence of 62 different behaviors on a 5-point scale, from never to very frequently. Again, they're asked to think about the child's behavior over the past 4 weeks. All items have to be completed. Again, you can read items to any parents who may have difficulty reading at the 6th grade reading level. It is important to capture the date on the top of your form, especially since you probably will be receiving this more than one time. Okay, and again, this is pretty basic. I can go quickly through this. All scoring is done on the record form, and there are pretty detailed instructions for how to do that. Do take a glance at it and make sure items are completed. Ask a parent or teacher to complete anything that may have inadvertently been left out. The main scoring paradigms are T-scores and percentile scores. They both get recorded on the record form. And then we plot an individual child profile. Cynthia will show us some examples of that later. And we also note descriptives of strengths and concerns. I'll bring your attention back to the record form and to the profile, where any areas that are shaded in blue on the profile are indicative of a concern, and any areas shaded in gray are a strength. So we're always scanning for total scores and for areas of strength and weakness. Okay. So interpretation, again, you all know that raw scores don't provide any meaningful information. They're all converted to standard scores. And in this case, we have T-scores and percentile scores. T-scores are standard scores. I'll show the bell curve, but they show a child standing on the bell curve, on the normal curve. Basically, it tells us how many standard deviations from the mean the child's scores are. Those are T-scores, and percentiles, I'm sure you all know, indicate how many children in that standardization group have scores lower than the target child. Okay, so if a child, for example, earns a percentile score of 65, that means that 65% of children in the standardization sample earn the same or a lower raw score. A child who's at the 65th percentile has surpassed 65% of their peers on that benchmark. Okay, and then we're just going to show the bell curve just to show you how these standard scores work. The line in the middle is the mean. That means the value at which around which most people cluster. T-score sets that mean at 50, and then there's a 10-point difference that marks each standard deviation away from the mean. So a T-score of 60 means the child's score is 1 standard deviation above the mean. 40 is a T-score that is 1 standard deviation below the mean, and accordingly. And then you have the corresponding percentiles. And usually for percentiles, we are looking at a normal range between 16% and 84%. So that's the plus and minus 1 standard deviation. And then as we get further out from the mean, we start to have indices of more strength or weakness. Does anyone have questions about standard scores or the normal bell curve? I don't know how much statistical background people come into this work with. Okay, no questions about standard scores? Okay. Okay, so getting back to the DECA, protective factor scores reflect the child's strengths, therefore high scores are desirable. Protective factor scores of 60 to 72 are considered strengths. Protective factor scores of 41 to 59, those that cluster around the mean, are considered typical. For the protective factor scores, T-scores below 40 are referred to as concerns, because the child shows fewer of these protective behaviors than we would want. If a child receives a protective factor score in the concern range, we might want to be thinking about interventions that will help assist the child to develop those skills. Okay, and similarly for the behavioral concern scales, although in the opposite direction, behavioral concern scales assess problematic behaviors, so high scores are associated with behavior problems and low scores are desirable. High T-scores of 60 to 72 indicate concerns, and we need to plan some interventions to reduce those behavior problems. On the behavioral concern scales, there is no range of scores that are categorized as a strength. All T-scores below 60 are considered typical. Okay, so the interpretive steps for the DECA. First, we form an initial impression based on the total protective factors and total behavioral concerns scores. So first we look at those broad scores, but then we examine the pattern of scores across subscales to see specific strengths and concerns. And here the profile, because it's so visual, is very helpful. Something that may not be as obvious is when we have to determine if scores do vary, if these are statistically significant differences. Sometimes big gaps in scores still don't mean a significant difference between them. There are pages in the manual that help you look up if any difference between subscale scores are significant differences or not. So we look to that, to the profile and to where there are significant differences between scores. And then we look to identify specific behaviors of concern. Inside the record form, scores for individual items that are in the concern range are linked by horizontal lines. I don't know if you've noticed that. It's a small detail, but on any given item, a score in the concern range has some horizontal lines linking them. And then there are particular behavior concern items number 29 to 32 that we always look at for particular behaviors: fire setting, harming animals, self-injury, or self-criticism, because those are behaviors that we don't want to get lost in the mix of others. These items are not part of any subscale and they're interpreted individually. All ratings other than never are of concern for these particular items and should be addressed in an intervention plan. Okay, next slide. Okay, so in discussing results with parents, I think it's probably helpful and a good idea, if it feels comfortable to you, to share the child's profile with the parents so that they can visually see the pattern of strengths and weaknesses. It's probably not necessary, probably not a good idea to provide particular scores, even percentile or T-scores. And you may include something like this. The score that summarizes your concern about Max's behavior is in the typical range compared to other children his age. While this is important to know, I can see by looking at his profile that his scores in some specific areas are high when compared to other children his age. For example, his score on the attention problem scale is in the range of concern. This seems consistent with the problems you described to me in our first discussion. Does this seem accurate to you? So again, to share the results, to align the results with what the parent has talked to you about in other contexts, and to check in whether the score feels meaningful to the parent. We can say something like, the profile also shows that Max has strengths in forming relationships with adults and other children, and that will be a great help to him both in and out of school. I will work on developing ways for Max, you and his teachers, to help him improve his attention. So just a way to describe, without giving scores, what you're seeing in the child's profile. There's another example. I'll go over briefly. Jasmine has scores in the level of concern on the aggression and emotional control problem scales. She also has problems at the level of concern on the scales that reflect her relationships with adults and other children. Often we see, and this is confirming the child's history, often we see this pattern of behaviors in children who have witnessed violence and are in foster care, which was the case in this child's situation. So we're connecting the behaviors to the child's history. And we can conclude by saying we'll prioritize work that helps Jasmine feel safe and comfortable in her relationships with adults and other children, while we also work to help her learn to calm herself when she's angry and upset. And then to check in, does that seem like a good plan with you? Okay. So other uses of the DECA scores, again, to compare across raters in case that's of interest, to see changes over time, again, to look at treatment outcomes. And sometimes we can use the DECA if it ever is appropriate to check on eligibility for particular services by documenting particular concerns in the social emotional domain. Okay, so I'm going to stop. We kind of ran through the DECA. I'm wondering if anyone has any particular questions about the DECA before we move on. Okay. Okay, so the Parenting Stress Index is used as a measure in the field as an early identification of parent-child relationships that are under stress, so that interventions can be put in place to reduce stress. Let me say that I don't know why this went optional for the network. Maybe Kristen can help us understand. It's a tough measure to give to parents. It's kind of negative in how it presents items. It sometimes isn't the most strength-based measure to use with parents. On the other hand, it is very widely used in the field, so familiarity with it is important. Lots of studies use the Parenting Stress Index, and I believe the network initially picked this as a relational measure, as some reasonably convenient way to have some measure of the parent-child relationship. Okay.
I can jump in to provide some clarification.
Okay.
Sure. I mean, it's so with the PSI and also with several other measures, we made them optional over the past year. So since the pandemic hit, there were some challenges with, so sometimes with the remote treatment as well, just to accurately assess clients, and then also just the overall burden. We tried to reduce that a little bit. So of course our preference is to conduct these assessments, but we have tried to be a little bit more lenient in the past years. And then also with the PSI, as you noted, Susan, it can be a bit of a difficult assessment to conduct. And in the past few years, we've considered an alternative for this assessment, but for the moment, this is the one we will be using and would like to use.
And like I said, despite its limitations, it is very, very widely used in the field. So I think people have not found it easy to find a substitute. And also it does measure parenting stress, which is an increasingly important variable for us to all feel comfortable that we understand. Parents have always been under stress. Raising children is not easy, but now they're under particular stress related to the pandemic and all the other things we've all been going through. So it is useful to get some measure of parenting stress. This is divided into 3 different scales. Parental distress is attempting to measure stress that doesn't accrue necessarily from the child. We all know that parents have stress that come from all different kinds of sources. So this scale is supposed to be measuring more personal factors for the parent. I'm going to go to the difficult child next. The difficult child scale tries to measure how much stress is coming from the fact that this is in fact a difficult child. We all know that there are easier kids and more difficult children, and the difficult child subscale is trying to pull out how much stress is coming from the fact that this is in fact a difficult child. And then the parent-child dysfunctional interaction is really where the interaction between the parent and the child is a source of stress to the parent. Something is happening in that relationship or in that interaction that is stressful to the parent. And then we have a total stress score. Okay, keep going. Okay, this is the model or paths of influence. Basically, the theory is that whether it's personal distress or stress from a difficult child or stress from a difficult interaction, that all of those impact parenting behaviors and thereby impact child outcomes. That's kind of the theory of impact for this scale. Okay, again, explanation. We've just learned a lot about how stress impacts on the lives of families with young children, and about the need to ensure that parental stress is reduced whenever possible. I'm going to ask you these questions. The scale is the Parenting Stress Index, so I know of all the ways I may be helpful to your child and family and best support the relationship. Again, we tell parents that we'll share results with them and review the child's treatment plan. Okay. So in terms of interpretation, again, like with the DECA, we use both T-scores and percentiles as the benchmarks for the PSI, although they seem to lean more heavily on the percentile-based interpretive framework. Again, plus or minus 1 standard deviation is the 16th to the 84th percentile, so scores within that range are considered normative. Scores above 85, which is a standard deviation above the mean, are considered high. And scores in the 90th percentile, which is 1.5 standard deviations above the mean, are considered clinically significant. Okay. This scale has an interesting subscale, the defensive responding scale. We don't see that on too many other scales. This was intended to help you determine the extent to which a parent may show bias to present themselves in a favorable way and to obscure some of the stresses that are really impacting on them. So they say that a raw score of 10 or lower on this subscale suggests that either that the parent is intentionally trying to portray him or herself as a very competent person who's free from the emotional stresses associated with parenting, or that the parent is not invested enough in their parenting role, so is not experiencing stress. Sometimes I've used this with parents whose children are in foster care, and sometimes because they're not dealing with the child on a day-to-day basis, their scores don't reflect the usual amount of parenting stress. Or it could be that the parent, in fact, is a competent person who handles the responsibilities of parenting well, and is not unduly stressed. So the authors of the scale say that you use this score in conjunction with everything else that you're learning about a parent to help decide if they have a low score on defensive responding, to interpret which of these is most likely to represent the reason. Okay. So interpretation, again, we look at the total stress score, which is an indication of overall level of parenting stress. And the authors say that a score in the 91st percentile or above, which again is 1.5 standard deviations, reflects a clinically significant level of distress. And then we look at the subscale scores. The manual has lots of guidance for how you might interpret these different scores. I'll go over some of them. When the parenting distress score is the most elevated, and especially if it's above the 90th percentile, and if the difficult child score is below the 75th percentile, so again, the parent personal distress is high and the difficult child is not high, then the authors suggest that we're probably seeing a parent who's experiencing more personal stress that's not related to the child, and the focus should be on interventions designed to help the parent with his or her personal adjustment. Go ahead. If the difficult child score is above the 91st percentile, that suggests that the parent is in fact having a lot of difficulty managing the child's behavior. And we may be looking at a child who's not easy to manage, either due to temperament or activity level or other behavioral concerns. Okay. There's a lot of guidance on this one. If the parent-child difficult interaction score is high, again, it reflects the parent's perception that these interactions or the relationship is a source of stress. And then there's some guidance. Scores in the 96th percentile or higher suggest potential for neglect, rejection, or episodes of abuse triggered by frustration. But compare that score to others. If all three scores are in the 91st percentile, in other words, the parent is reporting high levels of stress across the board, there could be risk for abuse. But the authors suggest that if the parenting distress subscale is in the 75th percentile or lower, so that the personal stress level is not that high, then we don't worry quite as much, according to these authors, that the parent might lose control. And if the interaction and the difficult subscale scores are in the 91st percentile or higher, then we're likely, and the parenting distress score is 70th percentile or lower, then it's likely that the parent is in fact coping with a difficult child. So those are just some guidelines. They do make some intuitive sense, but they can also be confusing. Does anybody have questions about this? Pattern of strengths and weaknesses. Okay, and again, checking in with the parent about their total score probably is sufficient. I don't think we have to go into all the subscale scores unless you're struck by a difficult child score and you want to provide some validation to parents about the fact that this child's behavior may be a lot more difficult than other children. But again, usually just reflecting the total score and checking in with the parent about whether that seems accurate to them as a measure of their level of stress is probably sufficient for the PSI. Okay. Any questions about this one? I'm going quick because I don't want to, I know you'll be interested in Cynthia's case presentation. Okay, so let's move on to the PHQ-9. This is a screener. So the other two are more assessment measures, meaning they have many more items, they have subscales, they have norms. Those can be considered assessment tools. Everything else that we're going to talk about now is really a screener, meaning that we use these measures to kind of take a quick look at the variable of concern, and that if we get positive scores, we need further assessment. So we use the PHQ-9 to screen for parental depression. We know that parental mental health is very important to young children's development and that depression is a known risk factor. We also know that children may not improve if their parents are struggling with mental health problems, and that depression is a really common mental health disorder that affects at least 10% of parents and can be more prevalent among higher risk populations. We also know that depression is very treatable, so when we screen for depression, we want to get people for services because this is really a disorder that's very amenable to intervention. Okay. Next slide. I'll just talk briefly about the impact of depression on parenting, especially with very young children. Very young children need the active engagement, the serve and return interactions that really help wire their brains and help them feel in relationship to their caregivers. And that depression can affect people's level of energy, their interests, their ability to feel pleasure in activities. It can limit the serve and return interactions, or it can make parents a little bit more irritable and hostile with their young children. Sometimes, depending on the severity, it can result in neglect or social isolation. And we know that parents with ongoing depression often have children who have mental health and behavior problems. So for all these reasons, this is early in a child's life, and we want the parent to be at their best for their baby. Go ahead. Okay, so the PHQ-9, as you know well, it's a screening tool. It's based on the 9 symptoms of major depression. It very much is aligned with the DSM description of depressive symptoms. It's available in multiple languages. It too is said to be at a 6th grade reading level. It was designed to be self-administered, but we do know that sometimes we have to help parents with it. Okay, next slide. Okay, and in terms of introducing, this may be a little further afield from what parents expect when they bring a child to your clinic. So we may need to introduce this a little bit more. Parents may worry about how these results are going to be used. Parents worry about stigma. They worry about being reported to ACS, they have guilt. So, we might want to say a little bit more about this measure, something like most of the evaluation today has been focused on what you're noticing about your child. Of course, that's why you're here, but parent health is extremely important for young children. So we ask every parent who brings a child to this clinic the same questions about themselves too. One of the more common problems that affects parents is depression. And the PHQ-9 reviews symptoms of depression. You can review some questions with the parents to make sure they understand it and how to respond, or you can administer the scale entirely to the parent. Next slide. There have been some studies on the different ways of administering, and sometimes parents have been found to endorse more symptoms if they do it on their own than when they do it in interview. On the other hand, not all parents will be able to manage the reading level or fully understand the questions. So you have to, determine for each family what the best way of administering is. Go ahead. Okay, you've all seen it. So there are two ways to score it. You can either scan for answers to questions 1 or 2 that are in the shaded area. Questions to 1 or 2 in the shaded area are concerns, or you can do the total score, see if there are 5 answers to all of the questions that are in the shaded areas. And we have some score guidelines. Next slide. Okay, so scores of 0 to 4 are considered to be in the normal range, and scores of 5 to 9 are considered to be minimal symptoms of depression. 10 is really the cutoff. Scores of 10 to 14 suggest symptoms of mild to moderate depression, 15 to 19 moderate depression, and scores above 20 suggest symptoms of severe depression. Okay, next slide. And again, you can say to a parent, when I add up the numbers for the questions you answered, we'll say the total is 9. While this is a screening tool and it doesn't imply a diagnosis, this number sometimes means that the person is experiencing mild feelings of depression. How do you think that matches the way you're feeling? So check in with the parent about whether the score matches their own self-assessment. Okay. If the parent has scores in that normal to mild range, first of all, use your clinical judgment about whether that seems to match the other information you're gathering. Always look at question number 9, which is the specific question about suicidal ideation. And at this low level of scores, you can say to parents, now that you know these are symptoms of depression, if any of these symptoms increase in severity, please, let somebody know or speak to your healthcare provider. It's a good way of psychoeducation to help parents know what the symptoms of depression are, to ask parents to think about ways to promote their own wellness strategies at this range, and then to rescreen again if the scores were in the upper end of this normal to mild range. Okay. Scores in the 10 to 14 range are more suggestive of depressive symptoms. So more discussion with the parent about support and treatment is indicated. Parent can be involved in thinking about what would be helpful to them. Again, more psychoeducation about what the parent can do to promote their own wellness. And then for your own thinking, is this a parent who needs their own treatment? Could CPP or dyadic treatment be helpful enough? Because we know that those dyadic treatments do impact parents' mood and do decrease depression. But is the parent open to their own intervention, either at your clinic or somewhere else? And then yes, rescreen or otherwise check in with the parent with scores in this range over the next few weeks or months. Next. Okay, scores in the more severe level certainly need to be addressed. Really psychotherapeutic support of some kind really should be planned. Parent can participate in whether they think medication would be helpful if they want to try psychotherapy, but scores in that range really do have to be attended to. Okay. Always review the suicidality question. Any response to this question in a positive way has to be further assessed. You definitely should discuss with a supervisor, and somebody should be conducting more of a suicide risk assessment if the answer to this question is positive in any way. Okay. Just a quick mention that we talk so much about maternal depression that we sometimes forget about dads, and research shows that there are many men who also experience depression around the arrival or in the early years of their children's lives. So not a bad idea to ask about and see what we can learn about the father's state of mind and mood. Okay. I'm not going to go over the GAD-7 because of time constraints. It is formatted and organized very, very much the same way as the PHQ-9. GAD-7 is a screener for generalized anxiety disorder. It particularly targets generalized anxiety disorder, but it also picks up symptoms of many, many other anxiety disorders. Again, you score it similarly, and the scoring structure is quite similar to the PHQ-9, and that a score of 10 or above is in the range of concern. Okay, I've left all these slides in case you want more information. Everybody will get the PowerPoint on anxiety disorders, the impact of anxiety, but we just can't go into everything. Okay, lastly, the Adult ACE Questionnaire, and this is probably the one that requires most thought and sensitivity, but the ACE Questionnaire derives from the very, very well-known ACE studies that documented that adverse childhood experiences are both common and also that there's a graded and incremental impact on mental and physical health problems experienced in adulthood as the number of adverse experiences in childhood increase. Studies have shown that at a threshold of 4 or more adverse childhood experiences, the likelihood of engaging in high-risk behaviors and of having impaired mental and physical health disorders later on in life increases compared to individuals with fewer ACE scores. The ACE questionnaire is now used very widely in clinical settings to identify or to stratify those clients who may have the greatest need for support services. And it is sometimes used as a trauma screen in the network. I guess it's used a little bit as a trauma screen, but just be mindful that it does not include any traumatic events that don't occur within the family. So it's not a comprehensive trauma screen. This is the scale that clinicians most often struggle with, if they're going to struggle with anything, because of the personal and sensitive nature of the questions, and also because of the less obvious face validity for parents who are asked about their own childhood experiences when they bring their children for clinical services. So it does require sensitivity in administration. I can tell you based on lots of experience, and you may have already had these experiences, that despite its discomfort, most parents do appreciate that somebody's asking these questions, and often will say that, although it's hard. Nobody's ever asked them these questions before, or sometimes the response we get, I'm curious to know what kind of response you get. It's probably good to anticipate with parents before you do it, that this part of the assessment feels a little more personal, and sometimes it's good to do it in a second assessment session, so you're building on the rapport that you've developed till then. Again, studies show variability in responses noted based on whether parents do this by themselves or in the company of somebody. But you have to administer the way that makes most sense for that particular parent. Okay, these are just some norms based on the original ACE study that tell you, let's look at 4 or more, that in the general population, and this is a non-clinical population, in a general and somewhat skewed to middle-class population, 15% of women endorse having 4 or more adverse childhood experiences, 9% of men, and 12.5% across the board. Next slide. Again, you will probably find higher percentages of higher scores because you're in a clinical population. Certainly poverty affected individuals often have higher ACE scores. We all have run into parents who have experienced all 10 adversities. Just to mention, there is a Child ACE questionnaire. It's not part of the network's requirements. Some clinics do use the child and the parent questionnaire. Sometimes clinicians like to use the child one following up to the parent one to help mobilize the parents' protective instincts toward their children. Okay, so okay, just an explanation again by way of saying that it's okay, Nicole, keep going, because we're getting close to when we need to, yeah, so just to bring some sensitivity and to forecaution parents that we're going to be asking them some personal questions. And we can say that we know that our experiences growing up are important. They affect our physical and emotional health and can also influence the way we care for and think about our children. We can assure parents of the confidentiality of these responses. Okay. Okay, that's the measure. You all know it. Keep going. Okay. And again, there's really no scoring system. You score 1 for each category of adversity that's been endorsed. The total possible score is 10. We do ask parents to think about their experiences before they were 18 years of age in doing this. Okay. A high number of ACEs certainly suggests high levels of stress, a trauma history, often in the parent's history, often reflects reduced levels of social support and possible difficulties in parenting. Sometimes you may want to ask if a parent ever received therapeutic services to address these high number of adversities, just gives you a little bit more of their therapeutic history. Okay. In reviewing it, you can normalize. It is true. It's not just saying that many people have adverse experiences in their histories, that it is part of their past, and support their healthy coping as best you can, and help parents understand how important it is for them to reduce their own children's adverse childhood experiences. Okay. I think that is it, unless there are questions. I just wanted to leave time because Cynthia has such a great presentation. So I'm going to turn it over to you. And Cynthia will make this all, I think, come alive and be applied.
Hello. I was like, okay. So now it's my part. Oh, I was like, okay. So I just want to preface a little bit. I was like a little bit of information about who the clients are before I shared the assessments. This was a CPS referral, CPS because they were living in Long Island at the time of the incident. There was DV, verbal and emotional DV towards the mother. There was one incident of the paternal aggression towards the child, my client. Little boy, 3.5 years old by the time he came to us. Father reportedly took a fork and stabbed my client in the arm. I was like, because he was being a little bit rough with his baby brother. That point, a little bit under 6 months, I believe. So when mother shared this, when she was seeking help, there was a CPS case open, but mother was open to seeking services. So she was very cooperative. She is very cooperative. They're still with me. A very cooperative mom, really wanted the services. So all that to preface that I do believe at time of assessment that she was honest with these measures with me. Because I know that's something that Dr. Shinitz shared, that sometimes depending on which ones, I personally am also a little apprehensive whether or not I'm getting the truth, particularly with PHQs and the ACE. But in this case, she's very cooperative, still is very cooperative. I believe that these are valid. I was like, so let me share. Okay. Okay. Can everyone see?
Yes.
Okay, thank you, Dr. Shinitz. And just to make sure that this is moving along, can you guys see the ACE now when I share it? Or is it still the DECA?
It's yes.
Okay, cool. All right. So to follow the order that Dr. Chinitz did the assessments, I'll start with the DECA. I was like, it's not the order that I do them, but we'll start here. I was like, no, it will start here. I was like, so because even though this is a CPP case, right? Because it's trauma, mom was concerned about the child's opposition, what she identified as oppositional behavior. I was like, that he wasn't listening anymore, that he wasn't cooperative, that there were a lot of no's. Oh, and also a little bit background about that. They had left the home in Long Island. They were now in Queens, which is why they came to the child center. They were living with my client's aunt, so the mother's sister. There was another child, the cousin, 2 years older than my client. Difficult behaviors as well. So they moved into a home with a child that was already struggling with his behaviors, the aunt and the uncle. And it was my client, his mother, and the baby. And they were all in one room. I mentioned this because this comes up for mom later and informs some of the stuff that I see when I do a reassessment later on. So this is the home situation. So mom, at this point, they've been in the 2 months, I believe, by the time they came to us late June. Mom shares that her concerns are around the client's behavior. She has insight that there was trauma, but her concerns are about the behavior. So when we get to the DECA, and I like to use the DECA as my jumping off point when we start to talk about treatment planning, where I'm like, this is, this is the information about the behavior that I got from all the assessments we've done. How does that coincide with what you've shared with me that were your presenting concerns? There was a mismatch with the DECA, the pre-assessment DECA and mom's reports of oppositional behavior. The DECA, as per mom's report, only indicated that he wasn't in the typical range for emotional control and attention problems. Everything else scored typical. Self-control, initiative, withdrawal, depression, aggression. She had mentioned some aggression. That's why I mentioned it. I was like, all scored typical range. None of them more than one standard deviation when we're looking at them. So I shared this with mom. I was like, okay, the assessment we did about his behavior indicates that these are the two main areas of concern. There was a mismatch. I was like, but that doesn't make sense for what I'm seeing. And I was like, my favorite thing to say to clients around the DECA is, let's talk about it then. I was like, because it's not me making an assessment. This is your assessment. So let's talk about it. And that's where we were able to start the conversation around, let's look at it from a trauma point of view. As like his behavior, the oppositional behavior that you're mentioning, it doesn't seem like it's too high according to this, but we see it maybe informed by the problems with emotional control and maybe attention problems because he went from a home to a small room. I was like, because there's a change. We don't have dad anymore in the picture because his dad stabbed him in the arm with a fork. I was like, there's a lot of changes. This is traumatic for a child. And mom was able to join me in it. And like I said, she's very cooperative. But it was a talking point for us because the results of the DECA here were not what she thought they were going to be, based off what she had initially told me. I was like, I did a reassessment with the DECA, but I want to come back to that one. I want to continue with the assessments I did at the beginning. I was like, but I enjoy using the DECA as a talking point. I was like, we could scroll down and we could look at it here as like the grid, the area of need. That's the emotional control and the attention problems, but everything else is pretty typical. I met the child, fairly typical for 3.5, actually highly resilient, this client. I can say that he's actually very resilient, very fun kid to work with. I was like, but mom had expectations of his behavior based off what she had seen before. He was a calm child, cooperative, very good. I don't like it when clients use the term, but very good, well-behaved child. So now she was seeing stuff that was outside of that norm for her, and she thought it was problematic. According to the DECA, not really though, not anything we wouldn't expect. But then I did the PSI. There was no notable concerns with the PSI. I'm trying to, wait, sorry about that. I'm trying to move this. Okay, there was no notable concerns with the PSI. There was child scored maybe a little bit high in the higher end of the normal range for difficult child, which coincided with Juan's interpretation of his behaviors, that the behavior was the concern, but nothing really stood out. Her defensive recording was 15, so it wasn't clinically significant. There's a decent range. I used the PSI with this mom more as a talking point to try to focus more on the strengths of the child, because like Dr. Chinitz mentioned, it's a little bit negatively worded, the PSI. But I used it because it helps sometimes parents when they reflect in that. And this mom was one of those moms I was able to do that, where I would ask a question and she'd be like, well, no, my child's not like that. He's a sweet boy. He doesn't do things maliciously. He doesn't do it on purpose. I know he doesn't. So for this client, and I try to use the PSI like that also, it becomes more of a talking point about, well, yeah, I was like, tell me more about his strengths. Tell me more about how he really isn't completely out of control. I was like, the way that sometimes it feels. I was like, so that's what I use the PSI more for this client. I was like, there wasn't anything really clinically significant with it, not even parental distress. I was like, which is interesting because I did not do a reassessment of the PSI, but some of what I will share is based off clinical observation. I was like, the PHQ, which I usually do at first, I think most of us do it at first, intake was at the very end of the normal range. So she had a 4. She scored feeling down, depressed, and hopeless several days, and then feeling tired, having little energy, which coincided with what we expect with 2 children under 5, and having moved, and she was looking for work, and she was dealing with her nephew, my client's cousin, who has his own set of difficult behaviors. All that at the same time that she was still dealing with how we're going to balance the father visitation, because he has paternal rights to visitation, and her own experiences thereof. So that coincided with what I expected. It wasn't really elevated. But this more, for me, this PSI works more as a baseline for what I see later with this client family. But it wasn't anything that to really write home about, like we say, right? I was like, oh, a score of 4, that makes sense with what you're telling me. I was like, and then we moved on. I was like, she didn't really score. She indicated in the last question that none of this was making it difficult for her to function at this point. This was July. And then I did the ACE. She actually scored 0 across the board with the ACE. That's why I made the point to say that I was pretty sure that she actually was very honest with me and very forthcoming, because sometimes one of my major concerns with the ACE is that clients minimize or underreport. Personally, I've had a lot of situations in other cases where clients scored no's across this, and then months later they'll be like, oh, well, but this happened. And I was like, when did that happen? And they're like, oh, when I was 15. And I was like, oh, I asked that question 6 months ago. Interesting. But I understand that a lot of it is the trust at the beginning. We do these really early on. I try to save the ACE and the trauma questionnaire we do for the kids till second session at the very least. There is a concern, my own, I have to put this out there, my own clinical concern that I know I spoke with Dr. Chinitz about, where I feel very apologetic sometimes about having to ask these questions so early on. And there's a risk, of course, there of eliciting dismissive cues or feelings with the clients that might make them underreport to us. But all that being said, this was a very forthcoming mom. She was very there with me at the beginning when I explained at very intake that I will ask questions about the child and ask questions about you also, because I work within the dyad, we work with the family. It's about supporting all of you. She was very receptive to that, very cooperative. So I believe that this is accurate, and they've been with me now for 10 months. So nothing has come up that gives me an indication that she underreported here. But it does bring me to helping understand what happened with this case as time went on. A few months, 6 months, I started clinical observation. Unfortunately, I didn't do another PHQ. I started to notice maternal decline. She would be, this is one of the cases I saw in person. She would be coming to session, dark bags underneath her eyes. She used to come with makeup, not coming with makeup anymore. Well-groomed child, always had his hair combed, very cute child. I was like, but she was coming, she just looked more withdrawn, more declined. She was very focused on wanting to talk, part of the CPP talking points with the child about the fact that they didn't live in the home that they lived in Long Island anymore. That now they had moved into a small apartment in Queens where they didn't have enough space. There was no backyard. It was an actual home where they lived. The beach was within walking distance. She would share these details with me. She was very focused on that being part of the triangle in CPP. That did not seem to be something that was really affecting my client. Because when I would ask him, we would call it the blue home or the now where you're living. And he's like, which one do you prefer? And he would say now, because he has his cousin who he plays with, even though sometimes cousin's a little rough. I was like, he's not living. He would say dad's ugly to mean that is bad. And this is a very verbal child. I was like, so he would have no problems playing it out, but mom, I could see would just collapse every time we talked about this. And I started to notice more and more November, December, when I started to notice that mom was really declining every time we talked about it. She got to the point in around December where she would cry every time we talked about it. So I didn't do another PHQ, and hindsight 2020, I wish I had, so I could have gotten an actual screening for it. But But if we go down those PHQ points, I was like, she was little interest right there, just in what I had seen before. Down depressed, definitely almost nearly day. She would say to me that she can't sleep because the child, my client, and then the baby, she's like, she had no energy. She was tired. She got skinnier. I physically watched her get skinnier, so I knew she wasn't eating as well. And she would talk a lot about how she felt bad that she couldn't get her children out of this one room situation living with her sister. So I didn't do another PHQ, but basically hit on almost all of these 9 questions there. And I mentioned this and in conjunction with the ACE because it may help me clinically understand that she was carrying a lot of guilt for having exposed my client to the DV and the violence when she didn't grow up with it. I was like, so her ACE was 0. She didn't grow up with any of the adverse experiences that we see in a lot and that I see in a lot of my other populations. So she carried the guilt very strongly that she exposed her children to something that she didn't live through. She has insight. This is an educated mom. She was able to make that connection. She's like, this didn't happen to me, but now my children. Why did I do this to my children? That was paraphrasing something that she said to me once. And I was like, well, let's reframe it. You got your children out of a situation though. I was like, but I noticed these declines, and I used the PHQ I did at the beginning and the ACE as my baseline to see where mom was coming from, because then she started reporting that the child's behavior was getting worse. I did do a DECA reassessment. I was like, this one's over here. And this one does look different. This one, we have more areas, a lot of things dipped into areas of concern now. We had self-control was out the window, withdrawal, depression, emotional control, attention problems, that didn't change. It was still area of concern. And now we have a score for total behavioral concerns as well. However, because I had noticed the maternal decline, clinical observation, unfortunately, not one that I had a PHQ for, I was able to use this new DECA as a conversation with mom about where her tolerance was for the behaviors that maybe hadn't changed as much as she thought they had. Because she had very, very lower tolerance. And that's also, that one, I believe, Dr. Chinitz, that was in your slide about the PSI, that high parental stress could sometimes skew things. I didn't do another PSI. Again, hindsight, I should have. But I did the DECA again, but the behavior I was seeing in session didn't match what mom was saying. He was a little bit more elevated. I'll give him that. I was like, but he wasn't destructive. He wasn't trying to destroy my room. He wasn't acting out against me. I was like, always been a little attention seeking. I was like, but I'm used to seeing that in children that suddenly become older siblings when they were only children. But nothing I saw in my room really matched what mom was saying. And that, taking it at face value, what I was seeing from mom's decline. When we talked about this DECA, I had at this point pretty good therapeutic rapport with them. I did have a conversation with mom about how I'm concerned for her, that I'm concerned about what I've noticed with her decline, and that she seems to be struggling with the client's behaviors more. And she cried. But then it opened a conversation where I could ask if I could refer her for her own services at this point. I asked if she was open to it, and she was. And because the baby, my client's younger brother, was still underneath 18 months of age, I was actually able to refer her into our perinatal program, which is an IOP, I believe, a little bit more intensive outpatient. So 3 times a week, she has her own clinician, there's groups. But because I was able to use the past PHQs and ACE and this DECA based off and with my clinical observation, I was able to kind of tie together that this was maybe more to do with mom necessarily than my client, even though the DECA is the one that's for the client screening of behaviors. But a little bit of hope, right? As where they are now, mom's been in home services now for 4 months. She makeup again. She's coming made up again. I was like, smile, saying, I feel so supported in this program. I feel so much better, Miss Cynthia. I was like, I feel like people hear me. I feel like people are hearing me. We're still dealing with the client's behavior, of course. We're still dealing with that. But mom is in a much better place now than she was when I did this DECA again. I probably will do the DECA again, maybe in another few months. I don't want to do it too back to back, just to, so I could have a comparison of where her tolerance level for the behavior is now. But I was able to use what I gathered from these assessments. And I chose this case because I felt like it was able to be tied together pretty well. There was a golden thread throughout it to get mom help when she declined, even though she didn't originally screen for concerns for depression necessarily. She was right at 4, right at the end of the normal range. And it helped. I see them today later. I hope they're still okay. But last time I saw them, they were doing pretty good. Mom wise, I was like, she's still very focused on the client's behavior, but that's something we're working on. That's still part of the clinical progress, right? Process. I was like, but she herself is doing much better. And I do anticipate that her capacity and her tolerance to deal with the outbursts as they come, as we continue to try to process the trauma, will be in a better place now. Because that's actually what I told them. I was like, I need you to be a little bit more steady, more stable before we can talk about before we could talk further about the trauma with the client, because we talk about the house and you break down crying. We had therapeutic rapport. I didn't exactly say it that bluntly. I was like, but it was pretty there. We were there. I was like, and she's like, no, Miss Cynthia, you're right. I hear what you're saying. And I was like, okay, I'm going to refer you to our perinatal program. You okay with that? And it was actually a bit of a struggle. I was like, because it is a lot. It's intensive outpatient. She has to meet with her own individual therapist. And then there's 3 groups, 2-3 groups, I believe they have to join. Me and her therapist, from what she told me, I didn't communicate directly with her therapist. We're struggling for a few weeks to make her come. Because she was such low affect. She's like, it's, I have to go, I have to get the baby ready. It's too much. And I was like, we talked about this. I was like, I really need you to go from where you are to like at least a little bit more like 5 of functioning before we could move on with further with the client himself. But it was a bit of a push back and forth. I was like, but like I said at the very beginning, she is cooperative. She is one of those moms that's like, for my child's best interest. So she did it. And when she started going consistently, that's when she bloomed in the perinatal program. Recently, she told me, I was like, my child's getting older. Am I going to still be able to continue going? And I'm like, I'm not entirely sure because I don't work with that program. I was like, but that's something to talk about with your therapist. And we'll try to work with you, because she's actually really attached now. But that's why I chose this case. It's not over. We're not completely in the clear yet, but it really tied in the way that mom declined, and then the way that we were able to intercede at this point to get her the services she needed based off the assessments that the network has us do.
Cynthia, I'm going to thank you for sharing all of that clinical material with us, and your description of the case and how you use these was very helpful. I'm wondering, because we only have a few minutes left, if there are any questions or comments, either on Cynthia's presentation or on the review that we did earlier. Give people a minute. I'll make a couple of comments while we're waiting to see if there are other questions. I thought that your discussion and description of how you use these measures as a point of discussion with the mother is an interesting use. I think, I touched on that earlier, but I think you really illustrated how you use the measures to check in with the mother about the accuracy, or to work with her on what you wanted to work with on her. So I think that is an interesting use of measures. I will also underscore what I said earlier about needing to have multiple sources of information, because as Cynthia's telling us, some of the early measures didn't exactly match what she was seeing. So that's why, a measure is just a measure. It doesn't give us any real royal road into the inner life. So we put multiple sources of information together. Okay, and I'll just say one more thing while we're waiting for questions. I ran a clinic that used a lot of measures, and I know that my staff very often completed the measures and handed them over to the program evaluator. That was in some ways their sense of what they needed to do, complete measures for our program evaluation. But I think there's really a lot of rich clinical data there for you to use. So I'm just urging you to not just pass them on and submit them, but really take a really good look at them. Do somewhat of a deep dive, because I think they will illuminate some of your thinking. Okay, so no questions? Just scanning. Okay, somebody said the case example was helpful. Yeah, I agree. Very good to have it illuminated. Okay, well, everybody will get copies in case that's a guide for you later on. If questions occur later, please reach out to us, or we don't have to confine to this particular session.
I
Nothing
guess
else?
I would just make a comment that
Yes.
I often see this with new cases, that the DECA score does go down after the first few months. I see that very often. It's a trend that we notice a lot.
That's interesting. I would not have predicted that. Do you have any thoughts about that, or?
I think that parents are not really that comfortable with us at the beginning. And I think they often don't give us a true score about their children. And I think once they become more comfortable with us, then I think that they are more likely to tell us the true version of the child and how they're doing.
Yeah, well, certainly,
I know the DECA
that's true.
points.
I'm sure that's true for the ACE questionnaire. And what Cynthia said about her experience is very, very common for parents to fill out an initial adverse childhood experience questionnaire for you early on. And then as you work with them and uncover more about people's histories, you hear very directly about aspects of history that were not endorsed on the ACE. And I think that goes very much to Celine's point, that trust builds revelation of things. But that is a really common experience with the ACE questionnaire in particular. The parents will often not endorse things that you come to learn about their histories. So again, we understand that as parents feeling concerned about how this information is being used, but also I'll remind everybody about the issue of avoidance in trauma, and that sometimes parents don't endorse things just because it's part of their avoidant or defensive strategy. So it's multifaceted why we get sometimes those low results on the first ACE. Okay, well, glad to see that you all have a comfort level with this. And again, we're always available, Gil and I and Cynthia with her experience, if any questions come up later.
And as a reminder, we'll be sharing, as Susan mentioned, the slides as well as the recording with you. And they'll also be posted in the ECTC portal for your colleagues as well who couldn't make it today. And I included the TTEC training feedback link in the chat box if you could fill that out before you go. Thank you.
Okay, thank you, everyone. Hope you all get out and enjoy this nice day.
Thank you, Susan. Thank